Okay, hello everyone. We'll have our title page slide shown here in just a moment. Thanks everybody for joining. Give a few minutes for everybody to get settled. Okay, looking to my colleagues for a thumbs up that we're all ready to go here. Got them. Okay, great. All right. Hello, everyone. I'm Dana Finnegan-Yee, one of the clinical Ipac coordinators for the Hub and Spoke program. Thank you for joining us today for the education session on surveillance. We are looking forward to working through the surveillance cycle, and we're going to discuss hopefully helpful information for you to take away to use in your facilities. This presentation will be a little more than 2 hours, but there will be a lot of interaction involved. So we're hoping you're going to enjoy it. To walk through today's presentation, we have 5 Ipac coordinators today, and my colleagues are Sarah Lee, Lana King, Caitlin Prentice, and Kim Craig. So we're all going to take turns throughout this presentation, taking you through some slides. Before we start, we just want to give some reminders while you're participating on this call. Could you please make sure you're on mute? If you're having any trouble connecting, please let us know in the chat. If you have any questions, please use the chat feature in Teams. And there will be interactive questions. So before we get into the nitty gritty, we're going to have Sarah review how to use Slido. So I'm going to turn it over to Sarah.
Perfect. Thank you, Dana. So first you want to go to slido.com in your favorite internet browser. So once you go to slido.com, it'll look a little like this. So under joining as a participant in the black bar there, you want to enter the code Ipac Hub. So it's IPAC HUB. There's no need to put that number sign there or a hashtag there. It's already there. But once you put the code in, it should take you into our event, which will look like this. So for the interactive questions throughout our presentation, we're going to mainly use the polls tab here. And if you see this logo on the side with the Slido logo and the Ipac Hub, that means there's going to be a Slido question coming up. So the interactions, again, will be throughout the presentation. So we recommend to keep the Slido browser open. So we'll have a test question first for those who aren't familiar with Slido. So the question will be, what is your favorite animal? So we'll give everyone a couple of seconds to make sure their Slido works before moving on. Okay, great. So we're going to now move on to the learning objectives.
Okay, thanks, Sarah. So hopefully everybody understands how to run through Slido there. And again, if you have any issues, just put them into the chat. We put the link there and the connect word there, Ipac Hub. So today's learning objectives are as follows. We're going to outline the importance of surveillance and the relevant requirements. We will review outcome and process surveillance and discuss the recommended indicators as part of your home's Ipac program. There will be an overview of the key components to an effective surveillance system, and we will provide you with some resources, tools, and considerations that will help with having effective surveillance. And Sarah's going to take us through our agenda now.
Okay, so in today's agenda, we're going to have an introduction to surveillance. So what is surveillance and why conduct surveillance? We're going to talk about the types of surveillance, break it down to outcome versus process surveillance, and then we're going to go into the cycle for outcome surveillance, go into some resources and tools and considerations for outcome surveillance, and then do the same for process surveillance. So going through a cycle and then some resources and tools for you. So now let's start off by turning it over to Kim to tell us what is surveillance.
Thank you. So what is surveillance? What do you think of when you hear the word surveillance? So if you could take a moment and get your Slido and just some things that come to mind when you hear about surveillance. So monitoring, surveying, watching, recording. Awesome. Next slide, please. So the definition of surveillance is the systematic, ongoing collection, collation, and analysis of data with timely dissemination of information to those who require this information in order to take action. So I would say that's a real mouthful. We're going to break it down for you on the next slide. So it's ongoing. Do you have a process? Collection, collation, and analysis. Is there a method that you're using? How are you interpreting this data? And then importantly, timely dissemination of information. So what information are you sharing and when is it being shared? Daily, monthly, weekly? And it has to go to those who require this information in order to take action. So who is getting these results of the surveillance and who is supposed to be taking action with them? Let's keep it simple. So surveillance is the routine process of gathering information, looking for patterns, and sharing your findings with those who can make a difference. Surveillance is not a single action item, but it's a process that should be a component of your infection prevention and control program. And the process is set up in a way that's similar to other continuous improvement cycles. So plan, do, check, and act. Next slide. Why conduct surveillance? So here's a Slido question for you coming up. Why does your home conduct surveillance? So when you think about surveillance collection, why does your home do surveillance? We'll give you a moment to submit an answer there. So we see monitoring trends, monitoring the residents' health, and monitoring healthcare associated infections. 3 great examples of reasons to conduct surveillance in your facility. So why conduct surveillance? So the goal is to reduce the risk of acquiring healthcare associated infections. Healthcare associated infections are common in long-term care homes, and they can frequently result in death. There's estimates that the rates of healthcare acquired infections in long-term care homes range from 3 to 7 per 1,000 patient care days, which is similar to what is seen in hospital settings. Outbreaks can be difficult to contain and they can result in significant costs to the organization. As the number of individuals who require long-term care is expected to rise dramatically in the coming years, increased resources for infection prevention and control can be an important factor to the overall health of these residents. And it's estimated that up to 70% of healthcare associated infections are preventable. An effective surveillance program helps to reduce the frequency of healthcare associated infections, which is key. Next slide. So we're thinking about surveillance and why are we conducting surveillance? So surveillance can be used for many purposes. Surveillance in long-term care homes can help to achieve the end goal of reducing the risk of acquiring healthcare associated infections. Firstly, we're going to detect and monitor our healthcare associated infections. Surveillance can establish a baseline rate of these illnesses at your facilities, and most healthcare associated infections do not occur in the context of an outbreak. So surveillance assists you in identifying these specific infections. We're going to identify risk factors for healthcare associated infections. So if you collect information about healthcare associated infections at your facility, you may notice there are specific risk factors. And other surveillance programs identified risk factors for long-term care, such as urinary incontinence, presence of an indwelling catheter, skin ulcers, and chronic conditions such as heart disease as increased risk. We're going to evaluate our preventative interventions. So once you have implemented a change as a preventative practice, data from the surveillance system can be used to investigate whether the measures were effective in achieving their intended outcome. And this data collected through surveillance can also identify if measures have been ineffective. And finally, we're going to provide information to inform, educate, and reinforce practice with our surveillance program. So regular contact with infection control practitioners could identify areas where changes could lower rates of infection in higher risk areas. Regular contact with ward nurses and the ICP, for example, during influenza season could help to reinforce infection prevention and control practices such as cohorting, droplet precautions, and surveying for influenza-like illness in residents. Next slide. So there are some mandatory requirements for surveillance in long-term care homes. We won't go into specific detail about these, but there is a requirement to detect the presence of infection in residents, and also the requirement to collect data and analyze trends, to survey for symptoms indicating the presence of infection, that have those symptoms be monitored. Licensees have to analyze daily to detect the presence of these infections, and then review at least monthly to detect those trends. And also, as I'm sure we've experienced over the last year, other surveillance protocols given by the director for particular illnesses and communicable diseases. And we want to be able to detect infection in the facility. Next slide. And then there's other requirements. So there may be surveillance requirement for other parties, such as if you're going through accreditation and whether there's other specific requirements they have there. Are there other provincial funding bodies that you're required to report to, or internal reporting requirements related to surveillance, depending on the larger company that you work for? It's important to be prudent with the best practice guidelines and standards that exist for healthcare facilities, in particular those PIDAC best practices. And so this is a summary of a couple of the PIDAC best practice documents. So there's infection prevention and control programs in all healthcare settings. And that's going to outline what the infection prevention and control program should look like, including surveillance and long-term care. There is a surveillance of healthcare associated infections best practices document, which outlines the process of looking at these HAIs and the qualities of an effective surveillance system. And then there's Ipac for long-term care homes, and that's a summary that combines the best practices and key principles, including surveillance for long-term care. Ipac Canada also has some positions that support long-term care surveillance. So there's an Ipac program components for long-term care, and then also surveillance in long-term care homes. And these are similar to the PIDAC documents and highlight the importance of surveillance in long-term care. So we have the mandatory requirements and best practices to support why we need surveillance programs, and we're going to look a little further at what we should be looking for and surveying in our surveillance program. And so Lana is going to take us through this next section with types of surveillance.
Thank you, Kim. So in this next section, we'll be looking at what you're looking for. So on the next slide, the main types of Ipac surveillance are outcome surveillance and process surveillance. Both measures will reflect the efficacy of the Ipac program in protecting the residents and staff while decreasing costs from infections. The type of surveillance and the method that should be based on the types of infection that are most important to the home and to the care provided and to the resident population served. So surveillance for some processes and outcomes is appropriately monitored on a continual basis, and others may be monitored periodically. So to look into both of those types of surveillance in a bit more detail, outcome surveillance monitors targeted outcomes using surveillance for both healthcare-associated infections, so looking at changes in the resident's health status that can be attributed to preceding care and service. An example of outcome surveillance related to infection prevention and control is surveillance of acute respiratory infection rates. Process surveillance monitors targeted Ipac processes with regular audits of practice, so things that are done to and for the resident at the home. An example could be hand hygiene auditing. So hand hygiene is a process conducted to protect the resident and the healthcare worker. So to conduct surveillance of this process, you could do hand hygiene auditing, monitoring compliance of the 4 moments of hand hygiene as an example. When we're talking about the goals of surveillance, Outcome surveillance goals are to identify clusters and outbreaks, to compare infection rates to benchmarks, and to measure internal improvements over time. Process surveillance goals are to improve practices and processes and to provide feedback and identify gaps in practice. The importance of surveillance goals is to have an understanding of what is happening through monitoring, tracking, measuring to help make improvements and manage a situation. So a quick visual summary of what we've just discussed. Outcome surveillance would be the changes in residents' health status attributed to care. And next, we know that this would be process surveillance, the things that are done to or for a resident at the home. Keeping in mind that through the processes, there are many. There's lots of processes in place, and these could be related to examples of hand hygiene, environmental cleaning, PPE use and appropriate use at the appropriate time, screening measures, reprocessing. All of these processes affect the outcome for residents' health. Therefore, when we're monitoring the results of actions related to infection control practices and monitoring infection control practices, we can make improvements that improve the outcomes to protect the residents and staff and visitors. So I'll hand it over to Dana just to incorporate some more Slido quiz questions related to indicators.
Great. Thanks, Lana. So that was a really excellent explanation of the difference between process and outcome surveillance. So we're going to just give you a couple interactive Slido questions here to sort of test your knowledge in terms of, is this going to be an outcome surveillance or is it going to be process? So let's flip to the first Slido question, and hopefully you guys have a minute to just interact with Slido. So we'll give you a second to get sorted. But I'll read the question aloud for you to think about. So tracking facility-acquired Clostridium difficile infection in residents. So you're tracking C. diff infection. Is this an outcome surveillance or would this be process surveillance? So take a minute to think about it after the great the explanation that Lana gave us and figure out which one you think it is. And we'll give you a minute to enter that in Slido. Okay, and it looks like we're getting some answers in here. Look at that. We got 100%. Everyone has, so obviously Lana did a wonderful job explaining that because everyone knows that tracking C. diff infection in residents, this is outcome surveillance. So well done. Let's move on to the next Slido question. This question is, monitoring adherence to environmental cleaning protocols. Would this be outcome surveillance or process surveillance? So I'll give you a minute to think about that and enter your answer into Slido. Great. Okay, look at that. We have everybody's responded and 100% again. So yes, you're correct that monitoring, checking adherence to environmental cleaning protocols would be process surveillance. Well done. And the last quiz question we have on this section is monitoring adherence to acute respiratory infection screening protocols, would that be outcome surveillance or process surveillance? And again, I'll give you a minute to enter your answer. Some responses here. Oh, perfect job. Well done. A very, very good understanding of the difference between outcome and process surveillance. And yes, the monitoring adherence to acute respiratory infection screening protocols, that would be process surveillance. You're checking how well done people are recording those acute respiratory infections. So good job, everyone. And I'm going to turn it back over to Lana.
Thank you, Dana. So now that you can have a firm grasp on what outcome versus process surveillance indicators are, following that activity, we're going to discuss what outcomes or what processes you could track and monitor. So thankfully, you don't have to come up with this on your own. PIDAC has outlined the recommended indicators specific to long-term care home sectors, and these indicators are in the best practice for Ipac programs in Ontario document seen here. And it's nicely outlined in tables. So this is table 2 of the document outlining the recommended outcomes for surveillance indicators and easily identifying the indicators for long-term care in the highlighted section. So some examples would be tracking the facility-acquired respiratory rates of infection in clients or residents, as well as tracking the facility-acquired acute gastrointestinal rates. And another example would be tracking skin and soft tissue infections. And then on the next slide is table 1. So these are the recommended process indicators. Again, highlighting the section for long-term care. And some examples would include monitoring adherence to acute respiratory infection screening protocols for residents. And also cited as an example would be vaccination rates for residents. So this can include influenza and your pneumococcal vaccines. And under some of the staff indicators would be seasonal influenza rates and SHARP's injury surveillance. These indicators are continued on the next page. And just some examples would be adherence to protocols for hand hygiene, routine practices, and correct use of PPE, environmental cleaning, and remembering that these are the processes for monitoring, so the things that are done to or for a resident. So we know that those are lots of indicators to be considering, and the list is large, but it doesn't all need to be done at once. So first, determining what is the most important indicator for your home and focusing on those, and just starting small. So some of the things that can be done are just prioritizing the most important infections to be included in the surveillance. And the surveillance systems can also be adapted to balance the availability of resources that it will take for collecting the data and achieving the objectives for the home. And it may not be feasible to conduct the surveillance of all the infections at all times. So determining what will be monitored on a continual basis and what will be monitored periodically is sort of a way of breaking it down. And then going back to the Ipac Canada position statements mentioned earlier, this document, the Ipac Program Components for Long-Term Care, outlines the minimum recommended components of a surveillance program that each home could have. So just to take a look at this in a little bit more detail, just to highlight a few points. On the next slide, a minimum surveillance shall include, so examples are admission screening, active syndromic surveillance. So this can include your respiratory infections and gastroenteritis, and identification of sentinel events. So for example, invasive group A streps and any COVID cases. So thinking back to whether this would be outcome or process, we would know that this is outcome because it's tracking the health status to care received. And process audits, so compliance with routine practices and additional precautions can include hand hygiene, personal protective equipment use, environmental cleaning, shared equipment cleaning. And when considering if this would be outcome or process surveillance, we would know that this is process surveillance because we're monitoring the things done to and for our resident or client. And then within this position statement, antimicrobial stewardship is also mentioned. We won't get too much into that today, but just to mention that audits of prescribing or targeted antimicrobials can be used to identify target areas and assess the effects of stewardship, interventions, and the education. So I'll turn it over to Sarah for some more interactive Slido components.
All right, thank you. So like we said, we're going to go into some more Slido questions here. So it's going to be a couple of polls right now. So the first one is going to be about outcome surveillance. So the first question will be, what outcome surveillance indicators does your home currently monitor? So for outcome, we're thinking residents' health status, and we're thinking about healthcare associated infections. So what outcomes are you looking for? All right, looks like some people are thinking we're getting some respiratory infections, acute respiratory infections, acute enteric infections, C. diff infections, COVID-19, influenza like illness there. So great, that kind of got your gears going there. So we're going to ask a similar question. The first question we ask is to stimulate your thinking about what you do in your home. And this question might sound the same, but we're looking to see how many of the homes are looking at the certain indicators. So you can choose all that apply for your home. Back there. All right, looks like everyone's looking for COVID, of course, and a lot of you are looking for acute respiratory infections, acute GI infections. Okay, great. So we're going to do the same for process surveillance. So we're going to start with a word cloud just to get you thinking about your process surveillance indicators in your home. But what process surveillance indicators do you currently monitor? So for process surveillance, we're thinking auditing and all of the steps that you take to protect residents' health. All right, it looks like we're doing a lot of hand hygiene audits, hand hygiene compliance audits, some PPE, environmental cleaning, oh, a second cleaning there as well. So it looks like those are likely the top ones, but again, we'll do it for the numbers, a separate poll here, multiple choice, just to see how many homes are doing whichever process surveillance indicators. Give it a few more seconds. Okay, it looks like most of the homes are doing environmental cleaning audits, so adherence to environmental cleaning protocols and adherence to PPE protocols. That's great information to have. And just to keep that in mind while we go through the different cycles, just remember what your home's doing and how you can improve that or add on to that would be a good idea. So before we get into the nitty-gritty of the cycles, let's just take a quick stretch break. Just 20 seconds just before going into the next section. So you can take that time to stretch your arms, stretch your legs, take a deep breath to refocus. Okay, great. Now Caitlin's going to take us into the next section.
Perfect, thank you. So now we're going to go into detail about what the key components are of a surveillance system in your home for outcome surveillance. So PEDAC's best practices for surveillance of healthcare-associated infections outlines the key components for a robust and effective surveillance program, which can be found in this previously mentioned document. We are going to go through this document, taking out pieces applicable to long-term care homes and explaining these pieces to you. Although Kim already explained what surveillance was, we just want to remind everyone that surveillance is not a single action item, but a process. So let's jump into the key components. So these are the general steps when planning a surveillance system. As you can see, this forms a loop which allows for a continuous feedback loop of the surveillance system components. So the first step that we must start with is the surveillance planning. Above the first step is the recommended steps within each of the phases that we will discuss. So let's get started with surveillance planning. So with surveillance planning, as each home is different, an evaluation of the home needs to be completed. A first step in surveillance system planning is to complete an evaluation of the populations that are served by the long-term care home. And to evaluate the population in your home as a whole, you want to look at the type of residents. So, for example, is there an elderly population, immunocompromised, comorbidities, the key medical interventions? So, do a lot of the residents have indwelling catheters? Is a lot of wound care happening? And the type of infections at risk. So, is it respiratory, GI, UTIs, etc.? So by doing this first step in the assessment, it will establish what the priorities are for the surveillance system required at your home. So continuing with your assessment of the population, these are some of the types of questions that you can ask to assist in the assessment of the populations that are served by the home, including what are the most common diagnoses, what are the most frequently performed invasive procedures, what types of residents are at greatest risk for infection, and are there any health concerns emerging from the community? So since the evaluation establishes priorities for the surveillance system, then resources for surveillance can then be targeted to the populations at risk for the outcomes of greatest importance defined in these priority areas. Next, we will select the outcomes. So the next step in the surveillance planning is to select the outcomes for surveillance. So the first one is a facility-wide surveillance, and that is conducting surveillance of all infections in all residents at all times. So facility-wide surveillance of all infections is not recommended in healthcare settings. It is not feasible to conduct surveillance of all infections in all residents at all times, as this would not be an effective use of time and resources. So then we'll look at targeted surveillance, which is conducting surveillance of specific resident populations and/or infection type that have been identified as a priority. So for example, indwelling catheter associated UTIs. And we want to prioritize the most important infections in your surveillance system. What is most important? On the next slide, we will talk about syndromic surveillance. So syndromic surveillance of respiratory infections in GI should be undertaken in all long-term care homes. Syndromic surveillance helps with early detection in outbreaks as it is the detection of indicators of illness that is observed before confirmed laboratory diagnosis. There are other considerations to think of when identifying additional outcomes for surveillance, and that includes the frequency of the infection, the impact the infection will have, and the preventability of the infection. So most Ipac programs have prioritized the type of infections for surveillance that have the most important impact on the specific population that is served. The outcomes that are selected for surveillance should be reevaluated at least annually. So in long-term care homes, the preventable infections may influence what you choose to look for in outcome surveillance. On the slide, you can see some examples of preventable infections. So for acute respiratory infections in long-term care homes, lower respiratory tract infections like influenza are associated with high morbidity, mortality, and disruptions to long-term care services. So surveillance for ARIs in residents of long-term care homes is universally recommended. So another example of infections that contribute to the burden of healthcare associated infections in long-term care homes is skin and soft tissue infections, with many of these infections being preventable, especially where they result from skin breakdown and pressure ulcer development. Therefore, considerations should be given to monitoring skin and soft tissue infections, which is a common quality of care indicator in long-term care settings. So lastly is urinary tract infection, which many may be preventable in long-term care homes through the limited use of indwelling urinary catheters. These also contribute to the burden of healthcare associated infections in long-term care homes. So now we'll get into another Slido example on surveillance planning. So Forest Manor is a fictitious 100-bed long-term care home. Half of all residents are dependent on staff for assistance to carry out normal activities associated with daily living. Symptomatic urinary tract infections comprise 1/3 of HIIs, and 10% of residents have urethral catheters. Lower respiratory tract infections account for half of the remaining HAIs. So around 20% of infections are developed by residents are skin or soft tissue infections. So based on this population, what surveillance outcomes should Forest Manor consider monitoring? And just know that you can select multiple answers. So we'll give everyone a moment to just put in their answers. Perfect. So the answer, that's great. Thanks everyone for their contribution. So Forest Manor should conduct surveillance of lower respiratory tract infections, skin and soft tissue infections, and UTIs associated with indwelling catheters. And so just based on your own home's population, what surveillance outcomes would be a priority? So it's not a Slido question, but just take a few minutes, seconds to write down your answer and just to reflect on your own home. All right, so we'll move on. So next step within the surveillance planning is to use established case definitions for infection. We want to ensure that a consistent, standardized case definition is used for infection. And a multidisciplinary committee of Ipac experts established and implemented standard infection case surveillance definitions for HAI in long-term care homes. You can find it in this document on the slide. So it also is important to apply case definitions accurately and consistently. So ICPs should receive training in the consistent and correct application of case definitions for surveillance, and they should be periodically assessed in applying case definitions. We will now have an example highlighting the importance of consistent application of a case definition.
This is Sergio. He's a very skilled surgeon. He is always prepared to receive his surgical infection rates from the hospital's Ipac team. However, he's been repeatedly investigated searching for explanations for an elevated infection rate among patients undergoing his surgical procedure. Sergio paid strict attention to infection control practices. This did not result in a decrease in the rates of infection. Sergio is very concerned for the safety of his patients and is prepared to discontinue his practice to avoid further occurrences. After a closer look, it was discovered that the surveillance case definition included all surgical patients who had a positive culture with or without symptoms of infection. For other surgeons, the case definition included positive cultures and clinical signs of infection. Hence, patients who did not have symptoms had been included in Sergio's rate of infection, making it appear high. The high rates of infection were deemed the result of surveillance error, not of poor operative technique. Sergio did not abandon his practice and continued performing his procedures with great skill. The story of Sergio emphasizes the importance of uniform application of case definitions.
So next we'll move on to an example. Perfect. So Forest Manor conducts surveillance for UTIs associated with indwelling catheters and uses the recommended surveillance case definitions of infections in Canadian long-term care facilities. So on Thursday, one resident with a urinary indwelling catheter had a positive urine culture of greater than 10 to the 8 CFU per liter. The resident had no localized signs and symptoms. No blood culture isolate was identified. So does this resident meet case definition? And on the next slide, we'll give you the case definition so you can refer to that. And then we'll start the Slido poll of whether the resident meets case definition. So we'll give everyone a few seconds just to answer. The resident does not meet the case definition. There are two ways to meet the case definition. The first is to meet criteria 1 and 2. The resident does not meet criteria 1 as they do not have any signs and symptoms, so right away they don't meet criteria 1 and 2. The other way that they can meet the case definition is to meet criteria 2 and 3. Criteria 2 is to have a positive urine culture of greater or equal to 10 to the 8 CFU per liter, which they do meet. However, they do not meet criteria 3, as there was no blood culture isolate identified. To meet case definition, they must meet both criteria 1 and 2, or criteria 2 and 3, but they do not meet either of those as they only meet criteria 2. Perfect. So lastly, with surveillance planning, we want to ensure that staff have proper training to know what to look for, how to document and communicate what they find, and are able to tell that to the appropriate person. And we want to make sure that staff understand why surveillance is taking place. Recruiting champions is beneficial. So now we will turn it over to Dana.
Thank you, Caitlin. So we're going to move on into the surveillance cycle, and now we're on to the next step, which is data collection. Okay, so you can see that highlighted in red. We're going to go through this part of the cycle. Okay, data collection. So the details that were discussed earlier by both Lana and Caitlin, those details are going to help you determine the data that's required to be collected for your facility. But first of all, it's important to know what data you need and how are you going to go about collecting it. So this can be time consuming. So you want to be sure whatever method you choose is going to be consistent and easy to maintain. So you want to look at all your sources of data that are available for you and select the methods that are going to provide all the information that's required. So long-term care doesn't typically have the wide range of sources of information that are available in acute care to identify infections. Therefore, case finding in long-term care settings is probably going to rely more heavily on feedback from those that are directly involved in resident care. So some sources of data that are commonly used in long-term care include regular ward visits by the ICP or the lead for data collection. This is often very valuable and very necessary to get all your required information. There's also things like Sentinel surveillance forms. Those would be completed by staff on the wards and then they'd be collected regularly. These are an excellent mechanism for feedback from the staff regarding potential infections. On the next slide, this goes into, every home is different. So, and every home is going to have different priorities for surveillance and resources that are available. So case finding will vary from facility to facility. So these steps here on this slide can serve as a guide for collecting data required for a surveillance program. So we're going to continue with a brief discussion on what each of these steps entail. So to start, it's important to ensure that there is a data source for both the numerator and the denominator, and let's talk a little bit about what this means. Okay, so a surveillance rate includes the number of cases identified in a population at risk. So this means that those who have the particular infection would be the numerator, and the residents that are at risk for the infection would be the denominator. This would be during a specific time period that's selected for surveillance. So for example, like a month or a quarter. And then just to describe an example, if you are collecting data on UTIs for residents with indwelling catheters, the numerator would include those with infections that of course meet the case definition and those with a catheter over those at risk. In other words, the denominator would be the resident catheter days. And of course, we know not all residents have catheters, and we're going to discuss this a little in greater detail later on in the presentation. So let's look at a summary chart of different possible data sources on the next slide. Okay, so this table is from the PIDEC best practice document that we showed you earlier on, which is about surveillance, and it shows the different types of data sources that can be used. So it's a really good chart because it notes benefits and limitations of each method, so it can be very helpful to determine what's going to suit your facility best. So it's important to note, and this was already mentioned earlier in our presentation, that data collection via total chart review is not recommended. That's extremely time consuming, can be like 30 minutes per chart, and it requires that the charter record is complete with all the relevant information at the time of the review. So this can result in missing infections. So that's the first line there. The data sources like lab reports, unit rounds, and Sentinel reporting forms, those are commonly used, but all of those methods require time and resources. So there's typically a combination of data sources that's often used. The next slide just shows the remaining part of that table. As I mentioned, the Sentinel reporting forms, and then of course there's other methods there. So typically long-term care is going to rely more heavily on feedback from those directly involved in the resident care. On the next slide, so we're talking here, the next step is to assess the sensitivity and specificity of sources of surveillance data. So what does this mean? A surveillance program should consider sensitivity and specificity. Let's talk about that in a bit more detail on the next slide. So simply speaking, make sure you're recording true infections and not counting non-infections. So what is sensitivity? Sensitivity is the ability to count true infections. So the use of lab reports, cardiac screening, electronic case finding, those are data sources that are higher in sensitivity. Surveilling for things like fever in residents or looking for those residents that are on antibiotics, those are less sensitive sources because these types of things don't always mean infection. So use caution with what data collection method you decide on and the reasons why the combination of methods might be very important. So specificity, what is that? It's the ability to properly exclude infections that are not present. So those truly negative. A relatively high specificity is preferred to minimize the time spent confirming an infection. Let's move on to the next step. So it's important to choose the most feasible surveillance system for your setting. So whatever approach is going to be used, it's necessary to know whether it's going to involve active or passive surveillance. And it should be reasonable in the context of resources that are available to you. So let's discuss the difference between active and passive surveillance. So this table here on this slide simplifies the difference between active and passive surveillance. Active surveillance involves actively seeking out infections on a regular basis. This is usually done by the ICP or a lead. This type of surveillance typically requires a high level of ICP or lead effort and resources to be effective. Passive surveillance, it involves reliance on the staff to provide the infection information to the ICP or the lead. So the resident care staff would report infections or suspect infections to the ICP or lead, and this would require the least amount of ICP time and resources, but it is a less sensitive system. The next slide shows a figure from the PIDEC document, and it illustrates nicely the differences between passive and active surveillance. So passive surveillance systems would be, they can be associated with underreporting infections because they rely on information from staff who are less familiar with the application of the case definitions, but it might be the most reasonable approach because of resource constraints. Active surveillance is the recommended approach in long-term care homes because of the higher sensitivity associated with it. So when you're implementing the data collection system, it's very important to remember that homes that draw on a wide range of sources for information will detect a greater number of infections. The next slide shows how a range of information sources can be combined to identify potential infections. So this figure on this slide illustrates how different sources of information can be combined to quickly identify potential infections. It also demonstrates that follow-up is conducted to confirm those identified infections and determine if they're going to be deemed as nosocomial. We're going to discuss the criteria for nosocomial infections in more detail later on. The next slide is going to take us to the last step for data collection. So the final step is to review the information to ensure that the data set is complete. So in other words, make sure that all the relevant cases are included. So the data must be reviewed for accuracy and ensure that the reported infections meet the case definition as discussed earlier. This might require further investigation of cases that were initially identified as infections, but now require a more in-depth look. If it's determined that some cases do not meet the case definition for infection, then they must be excluded. So let's review a practical example of a long-term care home that's performing data collection. Okay, so we're back with Forest Manor. So at Forest Manor, ward nurses complete a form during each shift. This identifies the residents with signs and symptoms of UTI, skin or soft tissue infections, or of lower respiratory tract infections. The ICP then uses this form to follow up on the residents who have been identified with signs and symptoms of infection. What type of data source is used in this example at Forest Manor? So we're going to give you a minute to enter your response into your Slido. Give it a few more minutes for people to enter their answer in the multiple choice that's there on the screen. Okay, so the data source that's used in this example is the Sentinel reporting system or Sentinel sheet or form. So we were talking about that one where the staff at Forest Manor would write down signs or symptoms of infection, which is given to the ICP. So this is, so that would be the correct answer, the Sentinel sheets or forms. So it's this type of data source is when patient care staff complete forms where documentation of possible infections are noted. They're completed on a routine basis, often daily, and limitations are that they're time consuming and they might require additional resources. So good participation, thank you. So on to healthcare associated infections. As mentioned earlier, we're going to talk about how a case is determined if it's nosocomial. So in other words, you're going to determine if the infection was healthcare acquired. So when a particular infection meets a case definition, it should only be considered nosocomial if it was not present or incubating when the resident was admitted to the long-term care home. So more specifically, in order for an infection to be considered nosocomial, there must be no evidence the infection was present on admission to the facility or readmission following like a hospitalization or community visit. There must be no evidence that the infection resulted from a procedure that was performed at an acute care hospital or in a physician's office. And infections that occur more than 48 to 72 hours after admission, they may be considered healthcare acquired. The most important consideration is that a consistent definition be used. So let's review a few examples and I'll try to apply our understanding of what we just talked about of how to determine if an infection is nosocomial. So our first example is again at Forest Manor. There's a new resident admitted to Forest Manor. Upon admission, the resident did not present with any abnormal signs or symptoms. The next morning after breakfast, the resident exhibited an episode of loose stool. The resident experienced 3 more episodes of diarrhea over the next 3 hours. A specimen was collected and it was positive for C. diff infection. Is this infection associated with Forest Manor? Meaning, is it nosocomial to Forest Manor? Is it healthcare acquired? Take a minute to enter your answer into Slido. Okay, great. So some people weren't sure, and that's okay. But majority of people said that it is not associated with forced manner. So it is not nosocomial to forced manner. And as described, the resident developed symptoms the very next morning. It hadn't gone past that 48 hours or 72 hours after admission. So this infection can be linked to wherever the resident was before admission. Okay, so good job, everybody. We're going to do one more example. So there's a new resident, this is a different example. So there's a new resident admitted to forced manner with an indwelling urinary catheter. Upon admission, the resident did not present with any abnormal signs or symptoms. After 5 days, the resident developed a fever, acute pain, and purulent discharge around the catheter. A urine specimen was sent and a positive culture was identified. Is this infection associated with forced manner? In other words, is it nosocomial to forced manner? Let's take a minute for you to answer your answer into Slido. Okay, so again, there's a couple people not sure, so that's okay. But the majority of you have said yes, this is associated with forced manner. It is nosocomial to forced manner, and that's great because the key here was the 5 days. So it was 5 days after, so it's beyond that 48 to 72 hour window that they have when signs or symptoms develop following. So that would have been a healthcare associated infection to forced manner. So well done. So I'm now going to turn it over to Sarah.
Thanks, Dana. Now that we've collected some data, we want to know what to do with the data. So next we're going to talk about analysis. Let's make sure that we have the data that we need. Have we collected the number of cases or the number of infections? Hopefully yes. Do we know the population at risk? Hopefully yes. And do we know the time period involved for both numbers? If yes, then we can go calculate some rates. So the general rate equation is seen here in the blue box. So as Dana mentioned earlier on in the presentation, your numerator is the number of cases, of course, in a specific population during a period of time, and your denominator is the population at risk during that same time period. So just a reminder that your numerator population is always a part of your denominator population. And then you have your K, which is a constant. So don't be too scared from this K, because it's just a number that's used to transform the result into a number that is larger than 1. So for example, if we're using the rate of 4 cases per 1,000 resident days, it's a lot easier to work with than 0.004 cases per 1 resident days. So in the end, it also makes it a little easier to compare the rates. Usually the constant is 1,000 in the rates that we're talking about right now. So one thing we do want to look at is the incidence. So this measures the new infections within a population over a period of time. New means we don't look at the infections from previous surveillance periods and only the ones from this surveillance period. So your first instinct might be to put number of cases over the number of beds or maybe number of residents, but this would really depend on your population at risk and what infection that you're looking for. So will the number of residents at risk fluctuate through your surveillance period? For example, maybe due to admissions? So to take that changing risk into account, you can adjust that rate based on the length of stay or the length of exposure to a medical device. And by doing this, it provides a more accurate estimate of the risk of infection. So now we're going to go into a little more detail on what that actually looks like. So let's start by adjusting the surveillance rate for the length of stay. So let's look at our rate equation here. What is our numerator? So our numerator is going to be the number of new infections in that period of time in that population. And our denominator will be the number of resident days. So instead of using the number of beds or the number of residents, we're using the number of resident days. So you're probably asking, where do I get this number? So the total number of resident days, it's usually available from your home's billing department. So maybe talk to them and see if that's a number that you can get. So adjusting for the length of stay can be used for different infections such as respiratory infections, skin and soft tissue infections. And for the visual learners, we're going to put the numerator and the denominator into the rate equation so you see what it looks like. So as you can see, the numerator is your number of cases, and your denominator is going to be the number of resident days. So if we put it in an example, your numerator is going to be the number of acute respiratory infections in a time frame, let's say October. And your denominator is going to be the number of resident days. Next, we can look at adjusting the rates based on exposure. So if we plug in the numbers, we can put it into the equation, you can use this and we're going to get rates of device-associated infections, such as indwelling catheter-associated UTIs. So doing the same thing, your numerator, it's going to be the number of cases and residents exposed to the device, and your denominator is going to be the number of resident device days. So it's not just resident days, since not all residents have the device and not all residents have devices for the whole surveillance period. So it's really specific to the time that a resident is exposed to the medical device. So again, for the visual learners, we're going to put those two into the equation. So you have the number of cases and residents exposed to the device as your numerator, and the number of resident device days as your denominator. So if we use the example of catheter-associated UTIs, the numerator will be the number of UTIs in residents with indwelling catheters, and your denominator will be the number of resident catheter days. So other considerations for calculating and analyzing surveillance rates, you want to ask yourself a couple of questions as well. So ask yourself, one, how often are surveillance rates going to be calculated? Are you going to be calculating them monthly, quarterly, annually? What has your home decided to do for these rates? Secondly, it's also a good idea to organize your data in an electronic format to calculate your rates. So whether it's using a computer to track and monitor your resident surveillance data, it's a good idea. So the system, whatever system you're using, should allow for the analysis of the infection data, or at a minimum, let you export it to do analysis in another program. So why do you want to do it electronically? Why can't you just do pen and paper? Well, by doing it electronically, it is more efficient. So you'll be less prone to calculation errors. And of course, that is provided that your ICP is trained to use the program. So in places where there is no specific infection control computer program used to track infections, you can use a spreadsheet or a database program to help you as well. So next we're going to go into a Slido question here. So the population at risk for lower respiratory tract infections include all residents at Forest Manor. 61 lower respiratory tract infections were identified over the quarterly surveillance period. Forest Manor's billing department indicates that there were 16,940 resident days over this quarterly surveillance period. What is the rate of lower respiratory tract infections at Forest Manor for this surveillance period? Okay, good job everyone who put 3.6 infections per 1,000 resident days. That is the correct answer. So we'll walk through it. Just for everyone to understand. So the hint is all residents at Forest Manor are at risk for the respiratory tract infections. So what's your denominator? It's going to be the total number of resident days, which was provided. So the answer is 3.6 per 1,000 resident days. So we have the number of cases that was provided in the question. So that'd be 61. And then we have number of resident days also provided in the question, and then you just put in a calculator, you have your constant as 1,000, and you get 3.6 infections per 1,000 resident days. So next we're going to talk about the interpretation of an infection rate. So Interpreting the meaning of an infection rate needs the working knowledge of your home surveillance system and also knowledge of the changing risks of infection in your home. So to guide a long-term care home in the interpretation of a surveillance rate, we can ask some questions. So first, are the rates accurate? So are they correct? So it is recommended that all infection rate calculations are pre-programmed into your computerized system and or your spreadsheet or database that I talked about earlier. And using your computer is going to eliminate some of the potential for miscalculation, and it saves you or the infection control lead or the ICP some time, just because you can put it in and it'll do the math for you. It is also recommended to have another member of the infection control team review and, if necessary, recalculate the rates using your infection data just to make sure that they are accurate. Secondly, you also want to ask, are the rates substantially different from previous data? So at this point, your ICP is going to notice that the rate is very different from previous surveillance periods. You also want to ask, do these rates make sense? So the day-to-day activities of your ICP is going to give them a good idea of what type of infections are expected in your home. So they can use this working knowledge to see whether a rate that you're looking at seems reasonable or is completely out of whack. And this is going to be based on their ongoing observations. So if there's an unusually high rate of infection, it might indicate an outbreak. But if the differences are not explained by an outbreak, then the ICP should investigate whether there are other reasons for this. So reasons could be recent changes in the facility's practices. So is there a change in the surveillance methodology, such as case definition or changes to lab processes or results? Secondly, you also want to consider seasonal or weekly variations. So variations related to time. So for example, for seasonal variations, respiratory infections have a low frequency in the summer months, but may increase over the winter months. So when you're comparing your rates, you have to understand there are those differences as well. Lastly, you want to also consider your sample size. So is this difference in the rate related to your sample size? Is your sample size too small? A low number of events may result in instability in rates of infection. Next, it is also recommended that you compare your infection rates, but to what? So a couple things you can compare it to. You can compare it to the previous surveillance periods. For example, your previous month, previous quarter, previous year, depending on what the infection of interest is. Next, you can also compare it to benchmarks set by your own facility. So a long-term care home may set out goals of infection rates based on what can be achieved in their own home and compare their infection rates to their own internal benchmarks. Lastly, if it's available, you can also compare it to recognized standards or benchmarks. So when comparing infection rates to other long-term care homes, though, you have to make sure that you review and make sure the surveillance methods used by the facilities are all similar, such as case finding and case definitions, before you compare the rates so that you're actually comparing similar things. Next, you want to investigate the increased healthcare associated infection rates. So if you do find that an elevated infection rate represents an increased risk of infection and there's nothing else going on that may be causing this, then you should use a conceptual framework such as the chain of transmission as a model to suggest explanations for these rates and where areas of improvements to Ipac practices could help reduce those rates. So trying to find those gaps in practice. Next, you also want to discuss that with your infection control team. So once an ICP or infection control lead has the confidence that they've interpreted the infection rate properly, it's important to share this with other people on the infection control team. So where there are higher rates of infection is thought to reflect a greater risk of infection, this interpretation could form the basis of improving Ipac practices. So this flowchart here is just kind of a summary of the interpretation of data. It can take you through and you can take a look at that. This is also from that PIDAC document. So we'll end off the interpretation piece with an example, another example here. So the Forest Manor ICP noticed an increased rate for C. difficile infection, so CDIs, for the month of July. The ICP noted that earlier that month, 2 residents were admitted to Forest Manor from the hospital. Both were at the end of treatment for CDI. 2 other residents on that wing developed CDI mid-July and were isolated and treated. So it's going to be a multiple choice question in Slido, but what are the possible explanations for the rise in cases? So if you think back to like the chain of transmission or something, you can kind of walk through it and see what are the possibilities in terms of why this might be a rising in the number of cases we have. So you can select more than one, and we'll just give you a few seconds. All right, let's see what answers we have. Okay, we have some good answers here. So did not use the sporicidal cleaning agent, breach and isolation protocol, new CDI cases admitted to the unit contributed to a source, accidental sharing of resident washrooms as well, resident wandering. So those are all possibilities. And with different situations, you might find different gaps or different breaches in practice. So it's really just important to look at your own home and the situation that's in front of you and to identify areas where improvements to Ipac practices could reduce those rates. So next we're going to talk about communication quickly. So communication is key, and I'm sure you all know that communication is key already. So in terms of surveillance, communicating surveillance data, a surveillance system is only as good as what's being communicated. So if it only collects data but doesn't communicate it to the stakeholders, then it makes it difficult and almost impossible to reach that main goal of improving Ipac practices or the main goal of decreasing rates of healthcare acquired infections. So if that data is not being used to affect the change in Ipac practices, then your surveillance system isn't working. So communication can be targeted to different levels too, right? So first you have your healthcare level, healthcare setting level. So this is likely going to include your Ipac committee. So this routine communication provides a total picture of all infections of interest in the facility. So that might be your quarterly reports of UTI rates, skin and soft tissue infection rates, your ARI rates as well. Next, it could be targeted to care areas. So this would involve communication to a particular specialty care area. So let's say memory care that's focused on the risk of specific types of infections that are important to these specific groups. Lastly, you can also have special alerts and outbreak communication. So communication in these situations can be directed to all resident care staff following the identification of an emergent risk of infection and to remind or notify the staff of the required Ipac precautions in these situations. So communication in general, it's really important to know your audience. So who are you trying to talk to and what do they need to know? So all the information provided in the reports should be clear and easy to follow as well. And you should really only provide the information required. So you want to focus on that main message. The information should be presented in a standardized format since a lot of managers or healthcare providers don't have a lot of time for an in-depth review of that data. So whenever possible, you should also use visual aids such as bar or pie charts, graphs, and tables to display the surveillance data. This way, it can highlight your important trends such as an increasing infection rate, and it could be quickly identified when portrayed visually. This is just a quick slide about labeling your graphs. So just make sure you label your graphs and charts with the key features. So your title, your labeled axes, and your timeframes, just to make sure that your graphs are easy to interpret. So now I'm going to turn it over to Dana, just to finish up the cycle with evaluation. Oh.
Great, thanks, Sarah. So we're almost done this cycle of surveillance. We're coming to the last part of it, which is on evaluation. Okay, so a final recommended practice is to regularly evaluate your surveillance system, and this can be at least annually. It is important to determine how efficiently and effectively your surveillance system works. So this would be part of process evaluation. So you can consider improvements to your system. And it's important to how the information is produced, how it's used, so that to reduce the risk of the healthcare associated infection, which is the outcome evaluation piece. So one example of process evaluation would be having internal or external peers participate in a review. So for example, maybe an ICP lead from another healthcare setting who can help provide a helpful perspective and maybe new ideas and suggestions for improvement. For outcome evaluation, you can ask some questions such as, did the surveillance system detect clusters or outbreaks? That's very important. If it did, great. If not, okay, maybe we should make a change. Which resident care practices were changed based on the surveillance data that was collected? Is the surveillance of this infection still of value? Hopefully it is, and you can keep going on with it. If not, you might want to consider stop collecting data on it if it's no longer of value. So it should be expected that a surveillance system undergoes continual modification to make sure it's working towards improved infection prevention and control practices. So let's watch a video that's going to demonstrate an example of a peer review session to evaluate surveillance definitions. Here we go.
This is Casey. She's the infection control lead at Forest Manor. She has invited a couple of Ipac leads from nearby long-term care homes, an epidemiologist, and a coordinator from the Ipac Hub and Spoke team to join in an exercise that will assess the consistency of application of case definitions for infection. A series of charts from residents with suspected or confirmed healthcare-associated infections are selected at random, and all participants at the review apply case definitions, deciding whether a particular case meets the definition for infection based on the information available. The group discusses and challenges each other's application of case definition and comes to consensus on certain issues. This exercise assists in assuring consistency in application of case definitions, both within Forest Manor and for other long-term care homes in the region.
Okay, so hopefully you enjoyed that little video and it gave you an idea of how you could use some peer review to help evaluate your surveillance system. So the next slide is just, we're done that cycle. We've gone through the entire cycle. It's just showing you that cycle again for completion purposes. And then we're going to move on to the next slide, which just gives you some additional resources that are available. And these can all be available when you get a copy of the presentation. So I'm now going to turn it over to Kim to discuss resources in a bit more detail and the Ipac Canada Toolkit.
Thank you, Dana. So what resources and tools are available? First off, next slide, we're going to just review outcome surveillance. So outcome surveillance is monitoring changes in the resident's health status that can be attributed to their care received at the home. And the goals are to identify clusters and outbreaks, compare infection rates to benchmarks, and measure internal improvement over time. This long-term care home surveillance toolkit that's available contains 6 tools to help guide long-term care and conducting surveillance of infections in residents. This is an Ipac Canada surveillance toolkit adapted from Public Health Ontario, and it supports your entire outcome surveillance process. It includes a recorded tutorial on how to use the toolkit and is available to everyone. The long-term care home surveillance toolkit has 6 components, which we're going to show you over the next slide. So there is a surveillance readiness self-assessment form, which you can use to determine if your facility is ready to implement the toolkit. There is a daily surveillance tracking form, and this is used by frontline clinical staff to document signs and symptoms of infection. It does not replace documentation in progress notes or resident charts, and it's used as a tool for the ICP to collect surveillance data for easier analysis. I personally think it reminds me somewhat of a line listing where you're recording the symptoms, but it gives you a bigger overview, I think. There's surveillance training slides, which are used for training staff on how to use the daily surveillance tracking form, which, as I'm sure you can appreciate, is a critical component of using this toolkit properly. And then there are case definitions. So there's a summary of all of the case definitions. You can establish case definitions. So if you're seeing symptoms coming up on the surveillance sheets, how does that apply to the case definitions? And there are case validation forms that you can use to assist to determine if you're meeting the case definition. And there's a surveillance and database reporting tool. So it's a Microsoft Excel tool that you can use to collate your monthly data from residents who met those case definitions. You can enter cases into the surveillance reporting form, and it will calculate infection-specific rates automatically, as well as making summary graphs and generating those for you. So you can see how this is a really nice way for you to really seamlessly pull together that data that you're obtaining through your surveillance. And then it gives an easier way for the ICP to generate those reports and calculations and summaries. So some outcome surveillance tips and tricks. Getting started is the hardest part. You're going to start small because practice makes perfect. Consider additional support, such as the Ipac Hub. We're here to offer you support as needed. Be practical with considering what your available resources are. So you really don't want to bite off more than you can chew with the time and resources you have available. And is your team ready? So ensuring there is support from your leadership and staff. And we're going to take a quick 20-second stretch break. And then once we pick up from that break, Lana is going to take us through key pieces of our surveillance system. So take a breath, hands off your phone, and Lana will come back when you're ready.
So in the next section, we'll talk about process surveillance. So just a reminder on what process surveillance is and what the goals are. Process surveillance is measuring the things done to or for a resident during their encounter with the healthcare system. So an example of process surveillance related to infection prevention and control is planned audits to verify that procedures or standards of practice are being followed. And the goals of this are to improve practices and processes and to provide feedback and identify gaps in practice so that improvements can be made. And the pieces of the previous cycle that was walked through during the presentation can be implemented for process surveillance as well. So during the planning phase, the initial piece would be determining what processes will be looked at. So in doing this, you're determining who will be involved among the healthcare team for auditing and making changes, because this will involve more than just the infection control lead as the primary stakeholder. It's really a collaboration across the healthcare team. And process surveillance planning also involves how information will be used. So the objective measurements, will they be used as quality indicators? In the case for using it for accreditation, and as well how feedback during the audit and recommendations and follow-up and decision-making on results will be provided to the stakeholders or the healthcare team. So going back on the next slide to the PIDAC document, just a refresher of Table 1, the recommended process surveillance indicators, and we already talked about the examples there. And then continued on the next slide, just some the other examples, related to adherence to hand hygiene protocols and adherence to environmental cleaning through auditing problems Through auditing, problems or deficiencies can be identified, eliminated, and prevented before it reaches or affects the resident, resulting or involving an outcome. So highlights areas of good performance and recognizes a job well done. This is another desired outcome of auditing, and it's essential to provide that feedback. And it promotes and facilitates consistency of Ipac practices among staff in various areas across the facility and programs. So in terms of who we should audit anyone who has to perform the task in the course of their job duties. So this can include licensed or unlicensed health professionals, physicians, or those in training. And it's really important that the relevant staff are involved in the auditing. And so just to note, staff engagement is also key to success because auditing involves various healthcare members across the team. That will be involved in the data collection, the audit, performing the auditing itself, and the follow-up discussions on the changes. In terms of how to prepare staff, the auditing process is collaborative and involves combinations of clinical staff from different program areas, managers and supervisors, and specific disciplines involved in the process surveillance. So it's important to ensure that staff have the proper training to perform the task and that they understand why the auditing is taking place, and that there's an understanding that that deficiencies could be considered opportunities. So it's not always punitive, and having that positive perspective on the process surveillance and the auditing, and ensuring that staff are aware of the processes. So how this is going to work and who's going to be involved. It's going to involve the healthcare workers. Will the managers or supervisors be involved? And potentially, will there be a third-party involvement, like if the Ipac Hub was pulled in or public health was pulled in as a resource? And the surveillance plan or auditing process should always be kept up to date to be assessing the progress of the surveillance program as it evolves. So we'll just share with you a video from an auditing experience from a healthcare worker, will be referred to as Teresa, that moves through the initial stages of hesitancy and recognition of a job well done being a desired outcome of auditing.
This is Teresa. Teresa is a very experienced and dedicated member of the Environmental Services team. She's been working at Forest Manor for over 20 years. She takes her job very seriously and knows what can happen if resident rooms are not properly cleaned and disinfected. When Teresa and her co-workers heard about their new supervisor's plan to start auditing their work, they became very concerned about this. They were anxious and negative before the process had even begun. To decrease the level of worry and stress about the upcoming audits, the Environmental Services Supervisor worked with the Infection Control Lead to ensure a staff education session was held to inform them of the purpose of the auditing program. During this education session, it was highlighted that this program would promote the work of the Environmental Services team and show what a great job staff were doing. This evidence gathered would be proof of how well clean the environment was, and the intent was not for punitive reasons. It was explained that this process was also important to gather data for the accrediting bodies and to show leadership how well the cleaning and disinfection practices are being followed at Forest Manor. The staff members were still reluctant, but had a better understanding of the purpose and intent of the program. After the process began, Teresa scored a 95% on her first audit. Teresa was very pleased, and she now had evidence of what great work she was doing, and she was very proud of how the auditing program showed her excellent work. She wanted feedback from her supervisor on the area missed, as she wanted to obtain 100% on all future audits. She was no longer anxious, but excited for this process to develop further and continue.
So we hope you enjoyed that video that can just give you an example of how the impact of auditing that can have on staff and the positive perspective that can come of it when a job well done is highlighted for employees involved in the process. So just in terms of preparing auditors, once champions and auditors are recruited, it's important to ensure that training occurs from a knowledgeable lead. And this is important because training of auditors establishes reliability for auditors and their interpretation of the criteria that has been established as a part of that process. So they should know how to properly perform the audits and what this involves. And it involves document reviews, so review of manufacturer guidelines, policies, and procedures. Staff interviews are involved, talking to staff about how jobs are done, the equipment used to complete those, as well as observations. So again, what equipment's being used, what products are being used, and familiarizing auditors with the tools that will be used in the processes involved. So what systems will be used during the audit? Will it be paper systems or electronic devices or systems that they'll be needing to be well versed in? Processes are important, establishing if the audits will be routine or part of planned surveillance, and establishing the processes for collaborative audits, if it'll be a joint walkabout where it would be someone collaborating in the audit. And then practice audits are beneficial because they perform the auditing process with another auditor to ensure that people are comfortable before carrying out these processes. And it also works to achieve consistency. And I'll turn it over to Caitlin to talk about the next phase of the cycle for data collection.
Perfect, thank you, Lena. So now we'll go into the next section of the cycle where we'll look at how we should audit. So starting with the first, so when we look at auditing, we will look at two different types of auditing. So planned observation or random observation. With planned observation, it allows audits to be scheduled to confirm all individuals have the appropriate competency. So for example, we can assess if an individual wears PPE appropriately by conducting regular scheduled assessments to see this. However, a disadvantage with this type of observation would be that behavior during normal work cannot be determined. In contrast, with random observation, we can make an assessment on adherence, which provides information on real-life practice at work, but it does require large numbers of observations. It is beneficial for an organization to use both of these strategies. So we want to audit at regular intervals as determined within the organization. One of the factors to consider in the frequency is if there are high or increasing rates of healthcare associated infections, then those would be opportunities to audit. As well, in situations when there is a change to the equipment or supplies that are being used on site, those are also good opportunities to re-educate and audit to assess how staff are doing with it. So moving on, we will look at the next portion of the cycle. So we'll now look at analyzing, interpreting, and communication in process surveillance. So let's look at the ways on how feedback should be provided to staff. We want feedback to be specific so that issues can be appropriately identified, and by giving the feedback as soon as possible, then it allows for the issues to be identified and addressed. Feedback should also be given in a way that will help improve performance by being constructive. You want the person to learn, and doing so, if it's in a negative manner, will not be beneficial to the teaching moment. Now we will look at how do we provide this feedback. So there are two types of feedback that can be provided. There's immediate feedback that occurs right away when something is observed, remembering that immediate feedback is the most effective. And immediate feedback can be given by anyone, but a factor that comes into play with immediate feedback is whether there's a culture of safety present in the organization. So this safety culture allows for a blame-free environment that allows individuals to report errors without fearing punishment. This culture of safety also has goals to have safe operations and has collaboration to identify unsafe practices and find solutions. It is organizations with a safety culture in place that allows for effective peer feedback, as people are not afraid to speak up if they witness something unsafe. So the other type of feedback is planned feedback, and that is given at regular intervals. So for example would be a regular report that goes to the Infection Prevention Committee. So next we will look at how we use audit data. So audits can identify problems and may provide information on specific risks. This can then provide information that can lead to improvement. This data can also facilitate the organization in the development of improvement plans and priorities. Analysis of this could lead to solutions. So next we'll look at evaluation. So the final portion is evaluation. So just moving to the next slide. Perfect. So evaluate by performing regular reviews and adjust as required. An example could be looking at the number of audits that are being done and assessing if it is enough to produce good quality data. Another example could be obtaining feedback from your staff on how to improve the audits. So now we have a short video of a Ppe auditing scenario.
This is Forest Manor. The infection control lead for this home is making preparations to start PPE auditing. A plan has been drafted with important tasks noted. These tasks must be completed prior to starting PPE compliance audits on staff. The lead had a meeting with managers, supervisors, and charge staff to inform them of the goals of the auditing program and important items that would require their assistance to complete. All staff had to be informed of the upcoming audits, and certain educational components had to be signed off prior to commencement of the program. Communiques were circulated by managers, supervisors, and charges of each area that detailed reminders of where PPE was located, where to get additional stock, and how to properly manage supply. Additional donning and doffing education huddle sessions were offered to all staff, and attendance was recorded. Some staff were recruited to be champions and auditors for the program. They were trained by the infection control lead on how to properly perform and document the audits. After these tasks were fulfilled and the majority of staff were trained, the auditing process began. Auditors were trained to conduct routine planned observations. After an audit, some staff requested feedback on their performance in real time. Others were satisfied to wait for the report to be circulated. Once sufficient data was available, results were shared widely, but there were also unit-specific reports generated and distributed. The infection control lead was diligent in ensuring sufficient audits and observations were completed prior to generating reports to ensure good data quality. Areas where lower compliance was noted had supplemental education huddles organized to review proper practices. Feedback was requested by the infection control lead on any suggestions or improvements the staff felt necessary to improve the auditing program. Auditors that had questions were allowed to partake in additional audit training sessions, and they could buddy up with another auditor to ensure consistent auditing practices were taking place. This is an example of the continual cycle of process surveillance.
Perfect. So hopefully everyone enjoyed that summary example of process surveillance, and I'll now hand it over to Dana.
Thanks, Caitlin. So as we've discussed, we're going to talk a little bit about resources and tools that are available. So first, in the first slide, we're going to talk about considerations for auditing tools. So this chart shows you some considerations to think about and different types of tools you can use. So it's important to determine what works for your home. So do you have electronic resources? Do you have human resources? What will suit best? Paper forms, electronic forms, or maybe if you have money, paying for auditing tools. So this scale shows you a range of least to most expensive tools. So the lower cost on the left side, the lower cost but the high human resources are the pen and paper, the manual data entry, and the manual data analysis. So those ones are lower cost but take a lot of time and effort. In the middle, you've got a medium cost and some medium human resources needed, which are forms like those exported to an Excel spreadsheet with some manual data analysis involved. And then on the far right side of the slide, the most expensive but least amount of human resources needed are something like purchasing a software auditing tool, like for example, a hand hygiene software auditing tool that has automated data analysis that does it for you and produces beautiful graphs and things like that. So that's just an overview of things that you have to consider before you choose which auditing tool you might use. So let's proceed to a Slido question to kind of get an idea of what auditing is in place in the people participating in this call. So our question to you is, what kind of auditing does your home conduct? So if you can take a minute to enter your answer into Slido, that would be great. Okay, it looks like we're getting a few different entries into our word cloud here. So we're seeing quite a few people are doing PPE audits, and quite a few are doing some hand hygiene audits. There's a mention of cleaning audits, so that's interesting, but the majority of you are saying PPE audits and hand hygiene. So great, thank you for taking some time to enter your answers. So we'll move on. So this slide, you've seen it at least 2 times before in the presentation. So again, it's the table right out of PIDAC talking about recommended process surveillance indicators. So the 3 that are highlighted there: adherence to hand hygiene protocols, adherence to routine practices, or including the correct use of PPE, and then adherence to environmental cleaning protocols. Those are the ones that we're going to discuss in a bit more detail. So let's start with hand hygiene. Okay, so hand hygiene auditing, we know what that is. I'm sure you've heard about it. It's the process of making sure your hand hygiene techniques are being practiced in healthcare and following the recommended guidelines. So audit results of hand hygiene audit results are going to help you identify most appropriate interventions that are needed for hand hygiene education, training, and promotion. The auditor is going to have to conduct observations openly, but without interfering with the ongoing work. It's important to note that direct observation is the most common approach for this. So no matter what tool you use, it is essential to use a standardized, validated tool for accurate data collection. So let's have a quick look at some tools, paper tools that might be available. The next slide. So most of you might have seen the observation tool by the Ministry of Health and Long-Term Care. So it's kind of a complex tool that includes all 4 moments of hand hygiene. Hospitals have used the form like this for quite some time, but anyway, so most of you have seen that. There's also specific paper tools that facilities develop on their own. So here's a facility specific tool that they created for themselves and adapted that works for them. So you've got to figure out what works for your home. And of course, as I've noted, there are software tools for purchase, and we're just going to show you quickly on the next slide some features of a software tool that are obviously helpful, but we know these things cost money. So here's what the tool would look like. It's the software piece where you enter your data. You can click on different options while you're observing the staff member. And then you can see the lovely graphs that can be displayed and produced from a software system such as that, so that you can share it widely. So that's what could be, those are just some options and tools that are available. Can we ask you now, what type of hand hygiene, some of you that have entered hand hygiene auditing that's taken place, could you let us know what type of hand hygiene audit tool you use and enter that into Slido? So there's a list there, and I'll just give you a minute to enter what kind of tool you use at your facility. Okay, so the majority of people are using a pen and paper system, but it looks like somebody has an electronic database or system, so that's great. Thanks so much for giving us your responses there. We'd like to now, for those of you that do use a tool, can you tell us what specific tool you use in Slido? I'll give you a minute to enter your answers. So if you use the Ministry of Health and Long-Term Care paper tool, can you just let us know that? Or if you're using a software, what software is it? Or did you develop your own facility-specific paper tool? Okay, so some people have entered, they've developed their own tool. Some people are using the Just Clean Your Hands or the Ministry tool there that was shown. Okay, thank you for those of you that entered responses. That's great and helpful. Okay, continuing on, moving on to another type of auditing or monitoring adherence to PPE. So PPE auditing, well, we know it's the process to make sure staff are using PPE in healthcare and they're following recommended guidelines. It's very important to ensure that PPE is, if you're going to audit it, you need to ensure that PPE is actually provided and that it's used and maintained in a safe and reliable condition. It's important to monitor the correct and consistent use of PPE for the safety of staff and residents. And it is important to note that direct observation is the most common approach for this type of auditing. So the next slide has a few different tools that they're of course paper-based tools here. This is a CDC tool. You can look at that. There's also facility-specific paper tools as well. So you know, there are electronic software out there, but again, it costs money. So on the next slide, it shows you one of those types of software tools that you can use to generate the data for you. It is important to note that Public Health Ontario has indicated they have a PPE auditing tool that's to be released very soon. I think it's under review at this time, so hopefully we can, that will be something that will be very useful and available for you soon. Okay, so one more Slido question here about what type of, for those of you that are doing PPE audits, what type of audit tool do you use? If you can take a minute and enter that into Slido. Okay, great. So some of you have indicated that you're using pen or paper. So, and then a couple of indicated there's no auditing currently being done. Okay, thank you again for that information and feedback, and we will continue to monitoring environmental cleaning. So environmental cleaning, what is environmental auditing? Well, it's the process of ensuring that environmental cleaning techniques that are being practiced follow the recommended guidelines. The results of these types of audits are going to help identify interventions such as education, training, and process improvements. Some different methods are observational methods, which is like a visual assessment of cleanliness, performance observations, satisfaction surveys, and environmental marking. We're going to discuss that one in a bit more detail a bit later. And then we're going to move to the next slide, which shows us the PIDAC document. It gives us a broad overview of each method. So you can see on this table, there's visual assessment. It gives you a description of what the method is. It gives you also the advantages and disadvantages of each type of these methods. There's performance observation listed and satisfaction surveys where maybe a patient or a client would complete a survey and provide feedback on the facility's cleanliness. And there's pros and cons to all of these. The next slide gives you some information on environmental marking, and again, some advantages and disadvantages. So for those of you that aren't familiar with environmental marking, what is it? What does it mean? Let's watch another video here to help describe for you what environmental marking is.
This is Patrick. He's the Environmental Services Supervisor at Forest Manor. In addition to visual observation methods for cleaning audits, he conducts assessments of cleaning practices by doing environmental marking. Patrick works with the infection control lead to set up the program. Patrick is trained and ready to start. In preparation, he marks the predetermined high-touch surfaces with a fluorescent marker. It makes an invisible mark on the surface to be cleaned. The environmental service staff enters the resident room and conducts routine cleaning as performed every day. After routine cleaning is completed, Patrick checks the surfaces that were marked using a UV light. He notes the marks that were removed. This means the surface was adequately cleaned, and the marks that are still present, meaning the surface was missed or inadequately cleaned. He routinely conducts these assessments on a consistent basis. Patrick enters the data into his electronic program and the results are determined. He provides positive and constructive feedback to staff based on the results. He also uses the data to understand the training and education needs of the cleaning staff at Forest Manor. This type of evaluation ensures that cleaning and disinfection practices are following best practice standards so that staff and residents remain safe in a properly cleaned environment.
So hopefully that video was helpful in identifying what environmental marking is. Some of you might do that by the use of, I'm sure people have heard of GlowGerm and they do it for hand hygiene monitoring and teaching. It can be used to mark surfaces and use the UV light to check that those surfaces have been cleaned. So there's different ways of doing this, but hopefully that video was helpful in explaining that type of process to you. So the next slide shows you, so here's some tools that can be used to perform environmental cleaning audits. So this is an Excel sheet here that can help mark some high-touch surfaces and evaluate them. There's another tool there that can be tailored to work what suits best for your facility. On the next slide, this is highlights of a software tool that can be purchased that shows you results of your audits, and it does all the data analysis for you and gives you like red, green, yellow scores in terms of what areas might need higher attention. You can set a baseline or a benchmark, what your goal is, and then this tool helps identify areas of concern. So there are a few different software systems out there in case people were wondering about that option. But again, it can be done manually as well too. So one more Slido question here about what type of environmental cleaning audit. So for those of you, I know there wasn't very many of you that noted you're doing environmental cleaning audits, but for those of you that do cleaning audits or assessing the cleanliness, can you indicate please which type of environmental cleaning audits you perform at your facility? Just thank you. Okay, great. We've got a few different responses here. So the majority of people are using a visual assessment, and some are using performance observations, and there is even some that have noted environmental marking that's in place. So that's helpful to understand who's doing what. Thank you very much for your answers. So we're almost done here. I know we're getting over the time, but so a final tip, and you've seen this slide before for the outcome surveillance, but for process surveillance or auditing, again, start small. We know it's hard. It's very overwhelming. There's a lot of different processes you can choose to monitor or audit. So, just consider what might suit your facility best, being practical, and depending on what resources you have available. The next slide just touches again on, because there are some resources out there about antimicrobial stewardship. So you can see that there's two things from Public Health Ontario shown on this slide. But again, we recognize this is a very involved undertaking and we're not spending any detail today on this subject. So I'm going to flip it over now to Sarah for a wrap up.
Thanks, Dana. It's also important to mention other tools available to you if you're interested in auditing other Ipac practices. So Public Health Ontario has some checklists available. I'm sure all of you are familiar with the COVID-19 specific control measures one, but just to know, Ipac Canada has also other tools available as well. So some include management of cleaning and disinfection products, housekeeping, supply rooms, linen and laundry. They have a whole slew of resources available to members there. So just a quick summary of everything that we've talked about today. So healthcare settings, including long-term care homes, must monitor targeted Ipac processes with regular audits of practice. So we covered that with process surveillance. Healthcare settings must monitor targeted Ipac outcomes using surveillance for healthcare-associated infections in specific populations. So that's your outcome surveillance. And then this just summarizes quickly that cycle. So infection surveillance must include standardized collection of data using written definitions of infections, identifications of risk population, methods of measurement, description of data sources, benchmarks used for comparison, and results of a process and outcome surveillance must be analyzed and reported back in a timely fashion. So based on the surveillance results, a plan for improvement, including organizational accountability, should be developed. So we're just going to wrap it up with a couple final Slido questions. So first off, we're going to have this question again. What do you think of surveillance? But now maybe we can have different answers based on what we've learned from this presentation. So we'll give you a couple more seconds to fill that out. All right, looks like we have different answers popping up. So that was just to get you thinking about what you've learned during this presentation. And then for the next and final Slido question, it's going to be, what are the next steps to making, changing, or improving your current surveillance program? So just think about what your home's next steps will be. Okay, it looks like we have some answers here. So review current surveillance program, going digital, improving data collection methods, getting resources, training staff. So it looks like different homes are hitting up different areas that they might, I have identified that they need improvement on, but that's great. So just to wrap it up, I think a main message from this presentation has been every home is unique based on what their needs are. So really, if you're interested in setting up or improving your surveillance system and need some help, feel free to contact us by email, or you can reach out to your Ipac coordinators in your area, and we can definitely work with your home one-on-one to see what works for your home for that piece. So I'm going to give it back to Dana to see if we have any questions in the Q&A section to address.
Okay. Thank you, Sarah. We hope that you've all enjoyed this session. We know it's a lot of information to digest and think about. But if anybody has any questions, please type them in the chat, and we can discuss them. If there's any questions, just use the chat feature, and we do appreciate your time, and hopefully we can help in some way. You also can see our email to email us with any questions if you don't want to type them into the chat right now. Okay, I don't see any questions being typed in, so thank you again for everyone and your time, and we hope that this information will be helpful for you to take back to your facilities to use. Please contact us at any time.